All right, so next presentation will be by Ammoren Dohm. It's Improving Radiation Oncology Resident Communication Skills by Leveraging the DISC Assessment Tool.
Good morning, my name is Ammoren Dohm. I'm a PGY2 resident at Moffitt. I'm happy to be here to share our preliminary work on improving radiation oncology resident communication skills by leveraging the DiSC Assessment Tool. Being a PGY2 resident is illustrative of the communication and interpersonal challenges many of us face. For instance, this year during one block, I was working with an attending who expected residents to be roomed exactly on their scheduled time. And if the resident wasn't there immediately after the MA roomed the patient, he'd begin the consult without you. On the next rotation, the attending I was working with was nowhere to be found, many times 20 or 30 minutes after I had completed the consult. Working with different styles like these is common, not just for PGY2 residents, but all healthcare team members. However, these situations can be stressful and challenging, yet being successful is critical for team cohesiveness and optimal patient care. Unfortunately, communication skill development is poorly implemented and often not even taught in postgraduate training. Fortunately, at Moffitt, the illustrious Dr. Hoff has pioneered an emotional intelligence-centric training curriculum program based on the work of Goleman and Boyatis, using the 4-quadrant model of emotional intelligence, being self-awareness, self-management, social awareness, and relationship management. We are constantly seeking to implement strategies as a part of this curriculum to help residents improve these competencies. With the help of Gabriella Harmon in the Moffitt Organizational Development Department, we identified the DiSC Assessment Tool. This tool is based on the work of psychologist William Marston. Marston identified 4 primary emotions or behavioral styles associated with behavioral responses. These 4 styles are: 1, dominance, characterized by direct, strong-willed, and forceful; influencing, characterized by being sociable, talkative, and lively; steadiness, being and logical. DiSC is meant to be descriptive and not diagnostic. We are a blend of styles, but research has found that people most often gravitate towards a dominant style or 2. DiSC, like many psychological instruments, seeks to measure the abstract. So how do we know that it's providing us accurate information? One thing that we can ask is, how reliable is it? How consistent and dependable are these results? This is often tested with a test-retest. This is where a respondent will take the test or survey and then take it again at a later time point and receive a score from 0 to 1, with 1 being perfect agreement. The DiSC assessment has been found to have a test-retest score of 0.86. Another question that we can ask is, does it measure what it intends to measure? For instance, if we are saying that being direct, strong-willed, and forceful are characteristics associated with dominance, then these characteristics should be strongly correlated when surveyed. The Cronbach's alpha coefficient measures this correlation, again, on a scale from 0 to 1, with 0 being no relationship. The DiSC assessment has been found to have an alpha coefficient of 0.87. For those familiar with Lord of the Rings, these characters can be the embodiment of the DiSC style. So first you have Legolas, who's calm, calculated, introverted. You have Gimli, who's more boisterous, direct, strong-willed; Pippin, who's fun-loving and outgoing; and then finally Frodo, who's gentle, accommodating, and more of a soft-hearted person. Keeps bouncing around a little bit. There we go. So the DiSC assessment asks participants to respond to statements on a 5-point ordered response scale, indicating how much they agree with certain statements. We administered a modified DiSC assessment survey to the residents and faculty. The assessment categorized participants into a primary and sometimes a secondary preferred DiSC style. And then these results were used as a platform for a 1-hour case-based training session. So what I'd like to point out here is what's really valuable about DiSC is, rather than just categorizing or labeling people, it can be utilized to teach residents to flex or adapt their styles. It's really this application of DiSC where the real value lies. It allows the facilitation of the competencies of EI. For instance, if you look at this table here, you can take dominance as an example. So if you know that you yourself have this dominant style, you may need to be more aware that maybe you should be more patient with others, let others help more, listen, and give people more time to figure things out. Conversely, if you're working with someone that has a dominant style, you may need to limit your socializing with them. You may need to get to the point and focus on the goal when working with that individual. So we had 12 faculty members complete the survey, 10 that were clinical and 2 that were in the physics department, and all 10 of our residents. Results were fairly proportional. You might even say a close match, with faculty favoring the conscientious style more and residents favoring steadiness. So here's another look at the breakdown. You can see some respondents had 2 dominant styles. And I was also not surprised to see that both the PhD physics faculty favored the conscientious, or the more introverted and analytical approaches. In conclusion, we used the DiSC assessment information as a platform for training that was used to facilitate the essential leadership competency of EI. Our residents in our department favored the influencing and steadiness styles, whereas the faculty, the influencing and conscientious styles. The DiSC tool helped residents to be more aware of self and others, and trained and educated them about how to harness this knowledge to flex and adapt their styles to improve teamwork, communication, and patient care. Next year, we plan to incorporate the DiSC in quality improvement projects aimed at allowing residents to practice flexing their communication styles on interprofessional teams. I also envision the DiSC assessment training becoming incorporated into the onboarding process for incoming PGY2s. I also see the potential for this to expand department-wide to be utilized by all members of the care team. The DiSC assessment tool, I believe, has many other potential applications. Can you think of any for your department? Here are my references from my slides and also my contact information down at the bottom for any further questions.
All right, great presentation, great topic. Just a side note, Dan, I think David needs to be unmuted, but you know, I like this concept a lot. I've done some work in EI and it really hits home with me. This sounds like a bit of a Myersbriggs almost, except specific to communication, not really designed to tell you what to do or change, but to help you understand preferences and styles and to adapt. It's funny, I've been now asking med students what do they think the hardest part of residency is, and they always give me literature and stuff. And I said, no, it's dealing with people that you may or may not like vibe with very well. So I'm very happy to see a project like this. One question that I wanted to have for you is that a lot of EI metrics or curriculums, it's kind of hard to change because they tend to be very personality driven. So they require a bit of a longitudinal kind of curriculum as opposed to like one session, which a lot of resident QI projects tend to be. How do you envision anticipating that?
That's a great question. So I think part of the power of the information that's given by the DiSC assessment is the information alone that you can extract from a single session, I believe is extremely telling. For instance, you know, as a PGY2, every rotation I'm working with a new attending. And if I were to know beforehand, for instance, what the DiSC assessment survey for the attending I was going to work with looked like, that could give me a lot of information just at a glance and help me to flex or adapt my style for that rotation.
Very good. What about for the attendings? How do you see them, or staff in general, not trainees?
Yeah, so I think this has broad application. So it's not just residents that have to work with different people on a regular basis, but also attendings. You know, oftentimes there'll be a nurse that's covering for someone that's on vacation. There can be a lot of staff turnover. You know, residents are often new to attendings, and in larger departments like ours, oftentimes there isn't a lot of interaction with certain attendings until you're on that rotation. So I think it can be informative for attendings as well to sort of know what is going to be the best way to engage with the resident that's going to be coming through that rotation when they may not have a whole lot of background information or experience with them.
David, do you have any comments?
No, but I see that there's a question from the staffer saying, It's interesting to see overall residents model faculty styles. Do you think it's preferable to have similar styles between PGYs and faculty, or different ones that complement each other's strengths?
Yeah, that's a great question. I think that it could go either way. I think that there's a tendency, at least, I sort of implied that with my comment on the match, that oftentimes people feel more comfortable with others with similar styles. So, it'd be interesting to do research to see, do certain departments tend to favor matching residents that sort of match or are similar to the complement of styles of the attendings. But I also think, obviously, that there's value in working with those that have different styles, that learning to adapt to different styles or to take on some of the strengths of different styles could push you to grow and develop yourself beyond where your natural comfort zone might be.
Perfect. Thanks so much. Great presentation and some really interesting discussion there.